Coming up next on Primary Care, Alzheimer's disease, the fourth leading cause of death for older African Americans.
Now, it is important to keep in mind that memory loss in and of itself does not mean that one has Alzheimer's.
Hello, and welcome to Primary Care, the health show focused entirely on the health and care of African Americans. I'm your host, Dr. Lonnie Joe. The disease Alzheimer's is an emerging public health crisis among African Americans, according to the Alzheimer's Association. Alzheimer's disease is underreported in African Americans and often diagnosed at later stages of the disease, resulting in less effective treatment. Joining me to talk about Alzheimer's and its impact on the health of African Americans is Dr. Gwendolyn Graddy. Dr. Graddy is a board-certified internist and geriatrician. She is also the medical director of the PACE program, which stands for the Program of All-Inclusive Care for the Elderly. Dr. Graddy, welcome to the show.
Thank you.
Thank you for joining us on this very important topic.
And it is. Thank
Everybody knows about Alzheimer's. We even joke about it, say, oh, I must have Alzheimer's because I can't find my keys. Would you talk about, to our listening audience and viewing audience, what the real definition of this disease is?
Yes. So Alzheimer's is a form of dementia. Dementia is a generic term. Dementia is not a disease. Dementia is a constellation of symptoms. And the most common symptoms for people with dementia would be memory loss, cognitive deficits, problems with reasoning, and ultimately problems with caring for themselves. There are many different forms of dementia, but the most common type of dementia happens to be Alzheimer's dementia. There's also dementia, vascular dementia, which commonly we refer to as strokes or multi-infarct dementia, Parkinson's, Lewy body. There are many different types, but the most common form of dementia, and probably the one that results in the most injury as it relates to both the patient population as well as family, is Alzheimer's dementia.
So Alzheimer's is basically what the listening public, the viewing public, is going to be exposed to by virtue of the fact of a loved one, a family member, actually having the disease or symptoms of the disease. Speaking of symptoms, what are some of the early warning signs of Alzheimer's?
Probably the most common warning sign of Alzheimer's dementia, of any dementia, but in particular of Alzheimer's dementia, is memory loss. Now, it is important to keep in mind that memory loss in and of itself does not mean that one has Alzheimer's. You just mentioned not being able to remember what you did with your keys. I lost my keys for 2 days. I just found them this morning coming here. But that doesn't mean that I have dementia. Right. I just have too much stuff in my purse. But the most common and the initial sign, the thing that people will begin to think, is something wrong, is memory loss. And it's memory loss that impacts a person's ability to perform. It impacts a person's daily operation. So memory loss is the most common and the earliest possible symptom that there may be dementia.
So what should a family member be looking for?
Okay.
What signs and symptoms, okay?
Yeah.
Well, mom can't find her keys, I couldn't either. When should we say, listen, maybe mom needs to be evaluated?
Okay. So because memory loss is the most common and the earliest symptom, one also looks for memory loss that impacts the person's ability to perform their daily activities. So for instance, usually memory loss in Alzheimer's is the loss of memory of recent events. And so you discuss with mom, I need you to get up in the morning and do whatever it is that you ask mom to do. Mom will not remember that maybe 5 or 10 minutes later. So it's mostly recent memory that would be the problem or make you think maybe I better have mom evaluated. The other thing is the person beginning to have difficulty performing their usual operation. We call them activities of daily living. We don't think about getting up in the morning and going to the bathroom, or that we have to eat, or you walk across the floor to do whatever you need to do, or dressing or bathing. Those are things we do naturally. We don't even think about them. But the person with dementia may begin to also have problems with performing some of those activities of daily living. And that may be just enough of a clue for the family member to say, I better have mom or dad or my loved one evaluated.
This disease seems to be ravaging the African American community. how are we responding
Yeah.
to the onset, the treatment, the change in everybody's schedule? I mean, what kind of issues are really presenting to the family as a whole, taking care of a patient with Alzheimer's?
I think I'd like to start with the initial part of that statement and how it's impacting African Americans. I think one of the major issues right now as it relates to African Americans and Alzheimer's dementia is that the disease is being diagnosed later in African Americans. And the question should be, why are African Americans diagnosed later? We know that the diagnosis is important for impacting intervention. No diagnosis, no intervention. Or if the diagnosis is made too late, it's similar to cancer. The diagnosis is made too late, the interventions or the options for treatment are limited. So part of the issue is that African Americans are diagnosed later for several reasons. One reason is oftentimes that individual does not present, the family member doesn't present that individual with the symptoms because it may be felt this is a normal part of aging. You would expect this as people get older, but it may not be normal. The second part is it can be overlooked when an individual goes to a physician or primary care provider as being normal aging. So not only is the population that is experiencing this disease thinking maybe this is normal aging, but healthcare providers who don't have the knowledge and understanding of how Alzheimer's presents and what needs to be done may also be writing it off as, mom is getting older, don't worry about it, you can expect that. But that is not true. And so we need to change the mindset. When somebody presents with a problem with memory loss or something that's different, out of the ordinary for them, as providers, we need to take that seriously and we need to do some interventions to identify the cause so that we can appropriately treat them.
That is so true. I find sometimes that in the primary care arena, we're not even asking the right questions, and we're certainly not extending this whole concept of who the patient is. Mm-hmm. An extension of the patient is the family and the caregivers.
Absolutely.
Sometimes it's necessary to talk to them.
It is.
In a one-on-one setting in terms of what mom may or may not be doing. But here again, you point out something that's kind of pervasive in medicine right now. Primary care is at the forefront and the onslaught of a lot of the disease states, and people doing what they do sometimes have not taken this conversation to the next point to actually extract the information out of the patient and or the family member. How can we expand on this?
Yeah, that's a tough one, because part of the expansion on those conversations is, number one, we need to have primary care physicians. And as you know, what's happening right now is we're graduating some 16,000 medical students every year. And of that 16,000 medical students, a very small percentage of those are even going into primary care, which would be internal medicine or family medicine, obstetrics, pediatrics. But an even smaller number is interested in geriatrics. So it really starts, at the root of the problem is we have to be able to train and educate primary care physicians who know which questions to ask. Internal medicine is an important aspect of healthcare because there has to be a gatekeeper that makes certain that individuals get to the right specialties. But when you back it up a little bit and you look at geriatrics, it is equally important, and I'm gonna be a little bit challenging here. I'm gonna say it's probably more important, and why is that? Look at the demographics. Our population is continuing to age, and one of the largest aging components of our population, other than those over the age of 85, are baby boomers. And I think we both are baby boomers.
We're there.
And so we're not gonna have primary care physicians to care for that population, and that's gonna be a challenge for all of us, especially as the population continues to age, especially as we see more people with Alzheimer's, because primarily Alzheimer's is a disease of aging. Who's going to take care of these people? Who will know what questions to ask?
I was in Washington recently and heard the statistic, 11,000 people every day, 365 days a year, are joining the ranks of Medicare recipients, which is probably the largest population that this disease affects, at least to date. So the challenges are becoming greater. The resources to some degree are becoming smaller. And even with the resources that we have, they may not be being used properly.
That's correct.
That's an interesting set of circumstances and a real challenge to go forward with a disease like this. Alzheimer's patients, what other types of diseases do they suffer from that are related to the Alzheimer's and may actually impair their cognition?
Yeah, I think one of the major other components to keep in mind is that there are other diseases that would put one at risk for developing Alzheimer's. And unfortunately, the list of diseases that I'm about to say are more common in African American populations or people of color. So hypertension, diabetes, and cholesterol problems. All of those increase the risk because they affect the blood vessels of the brain. They increase the risk of people developing Alzheimer's. So those are some of the associated diseases that we may see with Alzheimer's. And then the other list of diseases that we may see that are more prevalent in people with Alzheimer's are behavioral issues. So unfortunately, sometimes an Alzheimer's patient can be seen as somebody with a mental illness because of associated behaviors, and often they need to be seen by psychiatrists. Depression is another common scenario that you'll also see in people with Alzheimer's dementia. So there are diseases that predispose them that we still have to manage, by the way, and there are other diseases that they may be at risk for as a consequence of having dementia.
A variety of factors. We're going to take a break. We'll be right back. Stay tuned. We'll be right back with more primary care.
I'm B. Smith, and I suffer from Alzheimer's disease. Brain disease affects millions. Unfortunately, minorities are underrepresented in research, so we may not be getting the best possible care. The Brain Health Registry collects vital information online for free. So please tell your story. I'm telling mine. Help find cures faster by visiting brainhealthregistry.org.
Welcome back to Primary Care. We're here with geriatrician and Alzheimer's disease expert, Dr. Gwen Gratia. Dr. Gratia, the majority of people living with Alzheimer's disease are cared for by someone at home, a family member, a caregiver of sorts that has been brought in. What toll does Alzheimer's disease take on the caregiver and the family?
Yeah. Because ultimately this is one of those diseases that will require total care by family members. And another part of this disease that makes it so devastating is a disease that causes you not to know who you are or the people who you love. I can't even imagine how devastating that would be for caregivers. So you're caring for someone that you've known all your life or who has taken care of you all your life, and this person now no longer recognizes you. And in some cases may even accuse you of doing things that obviously you haven't done.
Or become fearful of
Or
you.
exactly, they become very fearful. They become paranoid. And so the ability of a caregiver now to care for someone who no longer knows them, who they've loved and who has loved them, can be very stressful. And what we found is that caregivers suffer from conditions as a result of being put under that type of stress. They're more likely to have problems with heart disease, hypertension. They make more emergency room visits than the patient that they're caring for and may end up in the hospital. And then ultimately it's stress, and we all know now the impact that stress has on us in general. So these people find themselves under more stress. As a result of that, that impacts their ability to be productive, their jobs. They often miss time at work. They may actually lose their job and have other challenges related to that. So caring for the individual for Alzheimer's for the caregiver can be a very, very stressful situation, which is one of the reasons that we need to do better in terms of providing resources, of course, for the person with Alzheimer's, but we're going to have to do better with providing resources and services and opportunities for that caregiver.
An expansion of the approach to a disease that to date has only included the caregiver when they were available. Catch as catch can, whether the financial resources of the family were there. Our insurance look at this disease, is what you're saying, needs to be refocused on how we actually treat those patients and include those things that you're talking about.
As a society, we need to be looking more closely at what types of things does it take to help that caregiver maintain that person at home? Because ultimately, it still is less expensive and the quality is higher if you can keep that person at home as opposed to institutionalizing them. So we've got to look a little bit better at how we can help that, make that happen, and help the caregiver.
Several recent papers about how people across all disease spectrums do better if they can stay home as opposed to be putting in that. So.
And it's less expensive at the end, but quality is better. They tend to do better, they live longer. The quality of life for not only the patient is better, the quality for the caregiver can be better if they got the right resources. Right. So we can talk about that a little bit more though.
That's a novel idea, less expensive and better quality.
Absolutely. Imagine.
So we've attempted to diagnose this patient. We've attempted to assess their social needs and to deal with the family. Now it's time to treat this patient medically. How are we doing with treatment?
Treatment continues to be a challenge, and it also has to do with when the person presents. Because right now we're saying that there's 7 stages of Alzheimer's. There's the very earliest stage where usually there's no symptoms at all the way to the severest stage, which would be the 7th stage, where the person is unable to do anything for themselves. They're completely dependent, may need to be fed and bathed and toileted and so forth. So depending on when the individual presents with Alzheimer's also has an impact on what the treatments are. But let's talk about treatments. Right now, as of today, while we're sitting here, Dr. Joe, there is no cure for Alzheimer's dementia. As a matter of fact, as we're sitting here today, we still don't really know the cause. Now, we know what the result of the cause is, the plaques and the tangles and what happens in the brain when you look at it under a microscope, but we don't know what causes the disease, and we don't have a cure for the disease. We have interventions that we can use now, medications, that hopefully slow the progression, make it more likely that an individual can be maintained at home and that the family can continue to care for them. But the interventions in terms of treatment are limited, which is the reason. The next question would be, it's the reason that there's more need for research.
Absolutely. And like so many other disease states that we treat, early intervention.
Early intervention.
So we're making progress. We're not satisfied with the progress.
Not at all.
There's a little bit of a phenomenon that's occurring though, where we see the disease itself presenting from the age group standpoint of view, coming down the scale a little bit. We're gonna go to a break. When we come back, let's touch on people in their 40s and 50s who are being diagnosed with this disease at an early stage. We'll be right back with more primary care.
There are over 34,000 Daves in Southeast Michigan. Big Daves, medium Daves, baby Daves. At Henry Ford Health System, we're inspired by every Dave out there, and every Shannon, Cherise, Miguel, and Ahmed. Because no matter your name, we believe care should be built around you, not someone like you or near you, but care designed for just one person, you. Henry Ford Health System, all for you.
Welcome back. We're here with Dr. Gwen Gratia, Medical Director for the PACE program of Southeastern Michigan and a Alzheimer's dementia expert. We're having a phenomenal discussion about this terrible, terrible disease. If any of you have had family members that have suffered with this and been around their care and their transition that they make through this disease, you know how difficult of a situation that the patient is in and the family is in also. Gwen, this disease state is costing Medicare and the nation about $226 billion a year, and potentially this disease state is one of a handful that can possibly bankrupt Medicare if we don't do something about it. We touched a little bit in the last segment on treatment. Tell us about research and what kind of progress we're making.
So going back to the amount of money that's being spent, when we look at the amount of money that's actually going toward Alzheimer's care, it is not just hospital care or nursing home care or medication, because there's very little medication care, but it's all of those other costs that are associated with caring for someone who has Alzheimer's, especially for people who are trying to take care of them in the community. The interventions that we have, I've already mentioned, are limited. We have limited medications. The medications do not cure or stop the disease, by the way, and we need to be really clear on that, because sometimes people will think if I get mom or dad on this pill, it's going to stop the disease. It doesn't stop the disease. It may slow the progression, or it may slow some of the behaviors associated with the disease, but it doesn't stop the disease because we don't have the capacity to do that yet. One of the things, however, that we have not done well, in my opinion, professionally, is research for Alzheimer's. When you look at literature and you look at the amount of money that has gone into looking at doing research on different diseases, I'll use cancer as a prime example, and even heart disease. When you compare the dollar for dollar, the amount of money that goes toward caring for people with Alzheimer's, we know now is significantly more, especially in that last 5 years of life. Literature just came out in 2015 in the Annals that talks about the amount of money the last 5 years of life spent for Alzheimer's is almost $300,000 compared to heart disease, which is $170,000, and cancer is about the same. So there is something wrong with that equation when that amount of money is being spent on a disease, but the amount of money being used to research that disease is limited.
There's really a disconnect.
There's a disconnect.
Which impedes progress going forward.
Yes.
And going to get more expensive if we start talking about the onset and the presentation of this disease in earlier decades of life.
Exactly. So I think part of the reason that research hasn't been done is, and I don't know, it may be that this is an older population. It's thought that maybe their productive years and really what they have to get back to society is limited, unlike heart disease where the population tends to be a little bit younger. So we've got to get a handle on why we're not doing more research, and we can't just do research. That research must include more African Americans, because much of the research that's been done has not included African Americans or people of color. And so how do you know the presentation, how it may be different? How do you know how the medications may work, which may be different? How do you know those things if they're not included in research?
Absolutely. We are embarrassed by probably a list of drugs that we probably have come to the conclusion that we never should have used in certain ethnic populations because of their poor performance. And the only reason that we found that out is because we looked back instead of making sure that people of those ethnicities were included in those trials ahead of time. Right. We would certainly have not made that mistake a la tamoxifen and breast cancer, and I could go on and on. The onset of this disease being earlier is certainly going to impact the cost. But if somebody in their 40s and 50s now are developing signs and symptoms of Alzheimer's disease, that means that the cost is going to go up. The next reasonable thing should mean that the ability or the energy and finances put into research should go up also. What about the difference between men and women who suffer from this disease, or the onset and the different sexes for this disease?
Well, one of the things that we do know is that women tend to develop Alzheimer's more than men. The hypothesis behind that is because women live longer. And we know that women probably have a life expectancy anywhere from 5 to 10 years longer based on the population, based on the zip code, based on the ethnicity. But women live longer, and because right now Alzheimer's is still primarily a disease of aging, the tendency is that women have present more with Alzheimer's disease. There may be some other genetic factors, perhaps. There may be some chromosomal factors, perhaps. But predominantly, it looks like it may be related to age. They live longer, so they're more likely to present with the disease.
So we need to have more African Americans participate in clinical trials so that the outcomes can be more specific and directed properly. Why aren't we making progress in clinical trials as far as research is concerned?
Yeah. Again, I think part of the reason that we're not doing as much as we should be doing as it relates to research in Alzheimer's is I don't know that it's seen as a priority. When you look at research dollars, they determine what is considered a priority. What diseases should we be looking at this year? Which virus is it this year? What disease is it this year? Yeah. And again, I just think when you look at the population that's mostly, even though it's true, with the baby boomers, I think we're going to be seeing Alzheimer's present earlier. We will, but right now it's still a disease of the aging, and I don't see that as being a priority right now for research dollars. So we're going to have to do better. We're going to have to hold researchers accountable. You know, you don't do more research on particular diseases, you may have limited resources that you will get in terms of being able to do research.
Gwen, I can't let you get out of here without mentioning the PACE program and what it is that you are the director of here in Southeastern Michigan. Tell us about it.
Yeah, so the PACE program of all-inclusive care of the elderly, again, we know as the population continues to age that the need to take care of this particular population also increases. So our program is a value-based program that specifically looks at dual eligibles. So people who are eligible for Medicare and Medicaid, who are frail, who are nursing home eligible, but who want to stay in the community. This program uses an interdisciplinary approach, coordinated care, integrated care, to bring these people into our program, provide the services that they need, and allow them to stay home. We also have a day program, so those people with dementia, it allows caregivers to have a place that they know that their loved ones can go and be cared for, be provided for safely. So that's basically what the program is.
Outstanding.
Yes.
Thank you so much. We're sitting here
Thank
with
you.
Dr. Gwen Gratia, who is the director of the PACE program and Alzheimer's dementia research expert. Thank you so much for joining us on the show.
Thank
we'll
you
do
for
it
the
again.
invitation.
Thank you.
Absolutely. Thank you, Dr. Joe.
And thank you for joining us on Primary Care. I'm Dr. Lonnie Joe. Thanks for watching.